Well, good morning, everyone. Now, I know that it mostly isn't morning for you. In fact, we have 87 people joining in our conversation today from 23 countries and, wait for it, 13 time zones. So welcome. My name is Bernadette Tobin and I'm speaking to you from Sydney, Australia. The International Association of Catholic Bioethics is hosting 4 webinars in preparation for its colloquium in September in Rome on the ethics of pandemics. The IACB is a multidisciplinary bioethics community with members from all around the world. We're supported by the Order of Malta, and our main work is a colloquium held every 2 years, during which we work together to develop an agreed statement on an emerging ethical issue or a disputed area in bioethics. And our focus is particularly on healthcare of the vulnerable people in society. Now today we have 3 groups collaborating with us. We have the Disability Bioethics Workshop of the Pontifical Academy for Life. We are joined by the Catholic Theological Ethics in the World Church and by the Order of Malta. This is how we're going to proceed. We have 2 wonderful speakers whose brief is to help us identify the important and the difficult questions. Each speaker will have up to 15 minutes to outline his sense of those questions. And then most of our time will be spent in discussion, in what you might call question and answer. So as you have seen on the opening slide, the session will be recorded. We ask you to keep your microphones muted. And when we come to the second part of the session, Mary Kate Gorky from Georgetown will moderate that part of the session and explain how it's going to proceed. So, without further ado, I'd like to tell you a little bit about our 2 speakers, and then I'll hand over to the first of them. Dr. Xavier Symons is a postdoctoral research fellow at the Plunkett Centre for Ethics, which is here in Sydney. It's a joint centre of Australian Catholic University and St Vincent's Hospital, and he's an adjunct lecturer in the Institute for Ethics and Society at Australia's University of Notre Dame. His research interests include the ethical issues at the beginning and end of life, conscientious objection, the ethical issues in aged care, and pandemic ethics. His recently completed PhD was focused on the allocation of life-saving healthcare resources. Xavier has taught bioethics for several years and he's worked in various Catholic organisations. In 2020, he was awarded a Fulbright Future Postdoctoral Scholarship, and he will be Scholar in Residence at Georgetown University's Kennedy Institute from June to December this year, God willing. Our second speaker is Father Rob Allore. Father Rob obtained his PhD in microbiology from the University of Toronto, specialising in genetics and immunology. He then worked in the Department of Medical Genetics at the University of Toronto, studying gene expression in the nervous system. Rob joined the Jesuits in 1990. He completed his philosophy at Loyola in Chicago and his theology at Regis College in Toronto. During his years of training with the Jesuits, he continued his research activities at Loyola in Chicago, at the Montreal General Hospital, and at Mount Sinai Hospital in Toronto. Father Rob is presently the pastor of St. Mark's Parish, chaplain to the University of British Columbia, and he's also an adjunct professor of theology at St. Mark's College, and is affiliated with the Department of Zoology. So I think you'll agree with me, we've got two very well qualified speakers to lead us in our thinking about the important and the difficult questions in our general topic. So I'll hand over now to you, Xavier, to tell us what you think we should be thinking about.
Thanks very much, Bernadette, and thanks to the organisers of this event. It's a real pleasure to be able to present. So I'm just going to share my screen now. Yeah. Fantastic. It's as I mentioned, a pleasure to be here this morning, or this evening, or in the afternoon, or whatever time zone you find yourselves in. This is a truly international event, so I'm sure there are people tuning in from all over the world. And I'd like to use this presentation to offer a very basic framework for thinking through the ethics of COVID-19 vaccine distribution, because I think that we, in a sense, are lacking an ethical framework, particularly at a global level when we're thinking about the ethics of vaccine allocation. And I would argue, and I will argue in this presentation, that Catholic social teaching actually has a lot to offer in this respect. So I'm going to focus a bit on that. Following the introduction of this general framework, I'll look at three topics very briefly. Just the issue of vaccine nationalism, which is, I'm sure, been in the news around the world, certainly has in Australia. Then I'm going to look at the ethics of vaccine rationing, sort of intra-societal issues of vaccine allocation. And lastly, I'm going to consider what we might, if you were like, what we might think about the sort of the policy problems arising from the problem of vaccine hesitancy in different countries. So when people don't want to take a COVID vaccine, like how should we respond to that? I don't purport to be offering an exhaustive discussion of these topics. I'm just trying to lay out a few questions in a certain sense that will hopefully be of use during the Q&A. And I'm also glad to say that Father Rob will also be addressing some of the similar issues to the topics raised in my presentation, and will provide, I think, like a very enriching kind of complementary perspective on them. So there should be some nice overlap between the two presentations. So to start us off, I thought I'd just look at the idea of ethical principles for the distribution of COVID-19 vaccines, because one temptation I would suggest is that I think policymakers might want to sort of reduce the discussion when we're talking about, okay, how should we allocate COVID vaccines, particularly kind of at a global level, like what responsibilities do we have to other countries? There may be this temptation to reduce the discussion to sort of just this pragmatic discussion of the realities of the pandemic, the realities of resource scarcity, the fact that every country is suffering a lot at the moment as a result of the pandemic. And in a certain sense, the easiest approach to take in those sorts of circumstances is to basically try and guard your own turf, to sort of make sure that your own population is adequately cared for and receives adequate access to vaccines, and more or less to put that as your number one priority, and to see the sort of the plight of other particularly poorer nations as kind of morally secondary. But I would argue that I mean, drawing upon certain principles in Catholic social teaching, we can kind of nuance that perspective a bit, and that it is important to introduce a bit of nuance into this discussion. I think that it's also important to recognise that we have a range of political philosophical frameworks we can draw upon in this kind of discussion. I mean, obviously, the literature in political philosophy is very rich, and you've got kind of different lenses like communitarianism, or kind of an ethics of effective altruism or something like that. You might want to want to draw upon to try and think through some of these questions of distribution and distributive justice. But I'd argue that they sort of don't really have the resources. They're kind of limited, at least, in their ability to cope with these global questions, particularly. That I would suggest that there's a certain kind of balancing of perspectives in Catholic social teaching that I do think makes it as kind of a unique instrument or kind of framework to deal with the issues that we're facing in this pandemic. So that's sort of the motivation for this framework. I'm just going to introduce 3 principles now before going through a few issues that I flagged at the introduction of this talk. So first of all, I think it's good to think about the ethical principle of solidarity in the context of the ethics of COVID-19 vaccine distribution. I've got a quote here from Pope Francis. I mean, to preface this discussion, it's important to realize that solidarity is more than just a feeling of vague compassion or shallow distress at the misfortunes of people both near and far. I think that it's a firm and persevering determination to commit oneself to the common good of all humanity. And I mean, the quote here is taken from the Pope's address, one of the Pope's addresses during Christmas. But it's this idea that we cannot allow the virus of radical individualism to get the better of us and make us indifferent to the suffering of other brothers and sisters, letting the law of marketplace and patents take place over the law of love and the health of humanity. And I think there's something quite deep going on in this quote, and indeed in the writings of Pope Francis generally. I think the Pope is quite right in his claim that nations around the world, particularly developed nations, they're not really living up to their egalitarian and humanitarian commitments. There's a kind of a rhetoric of kind of global concern and a desire to kind of improve the standards of living of people around the globe. But there is this sort of this ever-present problem of I suppose like radical individualism, a throwaway culture, and so on that does tend to kind of hamstring governments in their efforts to address I suppose the concerns and the needs of society's most vulnerable. So I think that there's sort of intra-societal problems, but then there's also these inter-societal issues, the problems affecting humanity as such. And the Pope really is challenging us to basically to avoid seeing humanity through a lens of a sort of a hierarchical lens, I would argue, like a sense in which there is actually this kind of implicit hierarchy in humanity or hierarchy of concern that we ought to have, and that somehow people who fall outside our kind of national boundaries or even kind of like the boundaries of sort of the alliances we might have internationally, that they are of a lesser concern, that there is a need to re-examine this implicit assumption in a lot of policy discussions. So that's what I'd say about solidarity in this discussion. Then moving on to the principle of the common good, that basically vaccines are part of the common good, or they are a common good. This is a quote from a document released by the Pontifical Academy for Life and also the Vatican COVID-19 Commission, dealing with this issue of sort of the global need for vaccines. So, I mean, the Academy said that given its function, it's appropriate to consider vaccines as a good to which everyone should have access without discrimination, according to the principle of the universal destination of goods. And this is an important point. I think that I mean, if you think about the material kind of social, spiritual conditions necessary for humanity as such to flourish, in our current time, in the current moment in which we find ourselves, vaccines are very much a constituent element of the common good. And that's something that we need to take very seriously, I would argue, that we have a responsibility to not only consider the common good in our own societies, but also what that looks like in other kind of nations around the world, and to think through what kind of principles kind of complementary to the common good, the universal destination of goods, for example, might actually mean for us when we're considering questions of the distribution of vaccines. There's just a quote here which I'll just skim over very quickly, but it's basically a quote from the CDF, the Congregation of the Doctrine of the Faith, but basically capturing this idea that the common good is not just about the responsibilities of governments, but that basically every citizen has a responsibility to the common good. And it's actually part of civic virtue to consider getting vaccinated because of the collective action problem that is herd immunity or achieving herd immunity, that we can't actually attain levels of population immunity sufficient to protect its most vulnerable kind of members of our society unless everyone recognises their sort of responsibility to and kind of integral role in realising that good. So it is really a kind of a problem which draws upon everyone's personal responsibility and appeals to the kind of sense of civic virtue and civic responsibility of all citizens. This issue of kind of vaccination. And then lastly, a preferential option for the poor. I think that this is an idea that takes kind of, I think, comes into relief when we think about this idea of pharmaceutical marginality. It's a concept that the Pope's used recently, but that basically, I mean, in the realities of market economies, it's not uncommon for certain nations basically to just not have access to certain medical resources. That's just a kind of, it's taken as a reality of life, and that sort of certain nations are just going to have to live with substandard medical kind of infrastructure for at least the foreseeable future until kind of economic development occurs. And I mean, perhaps that may be true in some cases, an inevitable reality in some cases, but I mean, it seems like if we were to adopt that approach with COVID-19 vaccines, then first of all, it is arguably highly unethical to sort of just sort of accept that without kind of at least trying to consider how we might distribute the vaccines in a more equitable way. And secondly, that as many people have pointed out, the only way you get out of the pandemic is by protecting the whole world against the virus. I mean, pandemics are global by nature, and so unless you have a global solution, you're not really kind of dealing with the problem in its essence. So just something to consider, I think, as well when we're thinking about the ethical lens for vaccine allocation. Okay, so just to sort of touch on this topic of vaccine distribution and vaccine nationalism, I've got a graph here which just shows how basically COVID vaccines have been distributed so far, and the cumulative doses of COVID-19 vaccines per 100 people in different nations. So as you can see, there are some nations that are really surging ahead in vaccinating their populations. Israel is one particular example, which is basically vaccinated over half of the Israeli population, kind of eligible, those eligible for the vaccine, have received at least one dose of the vaccine already, which is quite a remarkable effort. And then you've got the UAE, the United Kingdom, the US, Italy, Germany, and so on. So the World Health Organization estimates that vaccines are now being administered in over 50 countries, but they are nearly all wealthy nations, and that 75% of the doses have been deployed in only 10 countries. Or to put it in more stark terms, out of the 80-odd million vaccines that have been distributed around the world so far, virtually none have gone to low-income countries. I was reading an article the other day, and the only kind of statistical outlier was Guinea, and that was only because that country had participated in a COVID-19 vaccine trial. So 55 people in the country had received a COVID vaccine. But aside from that, no low-income countries have received access to a vaccine so far. I mean, there is this idea that vaccines are basically a good that should be available to, made available to all humanity to the extent possible. And I think a good quote to consider is one from the director of from Tedros Adhanom Ghebreyesus, the head of the World Health Organization, who recently said that it's probably better to vaccinate a few people in many countries rather than many people in a few countries. And I think that kind of paradigm is something that we do need to consider seriously, that international agreements are needed and need to be supported in order to manage patents so as to facilitate universal access to the vaccine and avoid commercial disruptions, particularly to keep the price steady in the future. So there is this this initiative, as many of you will be aware, the COVAX facility, which is basically a kind of subsidiary of the WHO and the Bill and Melinda Gates Foundation are involved to basically ensure that everyone around the globe has equitable access to a broad array of vaccine products. So over 170 countries are signatories to the COVAX facility. And I mean, you could argue that early signs are fairly promising, but there is this question, like, is COVAX enough? Like, is this kind of mechanism, is the initiative kind of, or those coordinating the COVAX facility, are they responding quickly enough to the challenge of trying to vaccinate the world? So they have been criticised recently, indeed, by actually kind of a board member of the WHO recently said that the COVAX had been slow to secure vaccine deals and deliver doses to countries, and indeed the COVAX facility is yet to deliver a single vaccine dose to any of its signatories. So there is this concern that we've sort of created this organization to help with the distribution of vaccines globally, but it will in the end not necessarily deliver in a timely fashion. So that it is something to consider. I mean, it's easy just to presume that things are looked after because there is an entity existing to address the problem at hand. But I think we should sort of be cautiously optimistic about the COVAX initiative. To look very briefly at the question of intra-societal vaccine allocation, so how we ought to allocate vaccines within kind of countries themselves, presuming that there are vaccines available. So there's a kind of prior question that's not always true of, that's not true of many countries, at least currently, but presuming vaccines are available, who ought to be prioritised? So the principle of solidarity directs our attention to those most vulnerable members of a community, particularly those most vulnerable to COVID-19 morbidity and mortality. Countries have so far prioritised healthcare and essential workers, as well as those who are most vulnerable, the elderly, immunosuppressed, and people with comorbidities. So the ethical framework reference seems to be a desire to achieve the greatest possible reduction in COVID-related morbidity and mortality. And certainly the Department of Health and Social Care in the UK, that's kind of seems to be their kind of explicit aim. So they seem to be quite clear that that's basically the intention in kind of with vaccination, is just to sort of reduce the death rate as much as possible. And I would argue that's kind of perfectly compatible with the framework that I've outlined, and sort of it's very logical and kind of makes ethical sense. It is, however, important to kind of be aware that the social determinants of health do play into how communities are affected by COVID-19. And I mean, the United States is a good example, how Latino, African-American, other sort of minority communities, Indigenous communities have been affected disproportionately by COVID-19. I mean, that should give us reason to consider their needs first in the allocation of vaccines. So this idea that priority should be given to ethnic minorities, both migrant and Indigenous, as well as people with disabilities, prison populations, people experiencing homelessness, and so on. I think there'd be a need to have a kind of a sensitive awareness of the nature of vulnerability given a particular culture and a particular society, because that will differ depending on the society that you find yourself in. So, I mean, in Australia, for example, the First Nations people of Australia have received priority in our vaccine allocation guidelines. And that's very appropriate given sort of the unique context of Australia and the fact that there is a massive disparity of access to healthcare and healthcare outcomes between a white kind of Anglo-Saxon communities and kind of the rest of the Australian population, basically, and then the Indigenous population. And then lastly, the problem of vaccine hesitancy. So I'm going to wrap up now just to make sure Father Rob has adequate time to develop some of these ideas, but also introduce, I'm sure, some very important nuance into what I may have said already. The problem of vaccine hesitancy is very real. I think that the data suggests we are going to come up against, once we actually do overcome this issue of scarcity, vaccine scarcity, we are going to come up against a very significant problem of vaccine hesitancy. in kind of countries around the world. Certainly, even some of the most vaccine-friendly societies in the world have a rate of COVID-19 vaccine hesitancy that's concerning. So approximately 29% of the Australian population have some degree of hesitancy towards COVID vaccines. Now, that should be put in context. It's not necessarily that they're not going to receive the vaccine, but they do have concerns, and those concerns need to be addressed in a satisfactory manner. And that rate of hesitancy goes up when you consider a nation like the US. So like 48% of the population has some degree of hesitancy about COVID vaccines there. So what ought we sort of say about these problems? I mean, I think from an ethical point of view, before jumping into kind of just sort of strategies for addressing vaccine hesitancy, we should return to this idea that vaccination or being vaccinated is actually part of acknowledging your personal responsibility for the common good. And society should, I think in a sense, it's a good time to foster a sense of collective responsibility for the common good in societies. A pandemic, so the silver lining of a pandemic is precisely this fact. And that we shouldn't downplay the value of appealing to people's sense of civic virtue and encouraging them to vaccinate. So I've sort of mentioned that in the slides here, and I've left a quote from the Bishops of England and Wales, but I do think that's something to consider in addition to other strategies to address vaccine hesitancy. So just to close, I've got into several debates recently about should we consider something like a compulsory vaccination policy? Should there be certain restrictions on travel based on whether people are vaccinated? Should we incentivize vaccination? I mean, my personal view is we should at least try less coercive strategies first. We should try and work with the population first to encourage vaccination and see how that goes in terms of vaccination outcomes, because I think that my hunch is that particularly in societies like Australia, at least, you'd probably be able to achieve sufficient rates of vaccination if you just used sort of sensible strategies, kind of tried and tested strategies for raising vaccination rates, and I've listed a few there. I'm not going to go into them because I think I better hand over to Father Rob, but I'm happy to come back to this topic in question time if you'd like. So I'll end it there. Thanks very much for listening, and I'll just exit share screen now. Yes. Thanks very much, Bernadette.
So, Father Rob, I can't see you on my screen, but I know you're there. So if you would like to take over now, I'll mute myself.
I'm here, so I just have to bring up a little bit of screen sharing. And I guess I have to open this to share it. I gotta find my document here. Seems to have disappeared on me. There it is. Is that working? Okay. Well, thanks very much for the intro, and thanks, Xavier, for leading us into it. Because of our preliminary conversations with the organizing group, there's going to be a fair bit of overlap in what I will say, but I'm going to take some different approaches to some of the same problems in the hope that after the presentations of the two of us, that there'll be good grist for the conversation mill. So just to situate us in the whole conversation, this sort of religious understanding of the call of Christians in the imitation of Christ to be healers, to participate in this vaccination and care for one another in the middle of the pandemic. We have so many experiences, so many stories of Jesus healing, but this one of our Lord encountering this man with leprosy. Now there was a man full of leprosy in one of the towns where he was. And when he saw Jesus, he fell prostrate, pleading with him and said, "Lord, if you wish, you can make me clean." And Jesus stretched out his hand and touched him and said, "I do will it, be made clean." And the leprosy left the man. We are not Jesus, but we are called in an imitation of Christ. And we know that some people will come to us and say, and that means nations too, "If you wish, you can make me clean." And I think we want to know, be aware of the obligation to respond, "I do wish," and do what we can to make the people clean and whole and safe from this virus. Related to that is the way I think Xavier's touched on a number of references about the church in the world. So, well, we say we are not of the world, we are in the world as Christ was in the world. And the church then has this tradition of saying that we are into the world in the particular perspective of the Christian, seeking healing and wholeness, seeking the human flourishing at all its deepest levels. And so in the documents from Vatican II and the Church in the Modern World from 1965, we have this statement that just rings beautifully in the challenges that are in front of us. The joys and hopes and griefs and anxieties of the people of this age, especially those who are poor or in any way afflicted. These are the joys and hopes and griefs and anxieties of the followers of Christ. Indeed, nothing genuinely human fails to raise an echo in their hearts. And also in Pope Francis's recent presentations, he's been really assertive at telling us that we shouldn't be caught in these either or worlds. It's the economy or the environment, it's the economy or the healthcare demands. And so Pope Francis has used this term taken from others, that in our activities, we must hear the cry of the earth and the cry of the poor. And this sort of mandate to bring healing and wholeness to people while being attentive to the cry of the earth and the need to create sustainable environments, it is actually one of the conversations that I think can be very fruitful globally right now, that we, as much as the need to deal with the global pandemic is clearly number one issue in many ways, there are a whole lot of other issues that we need to deal with at the same time. And so we have these phrases of build back better and the way in which the recovery needs to be thought of broadly while we think of the vaccine and dealing with COVID-19 in very particular specific ways. So I'd like to look at a series of about 3 themes that overlap very much with what Xavier has been saying. So but I'd like to look a little bit especially about the gifts of science and the way in which having a sense of what science is doing is part of the educational process that will help us with many of the other challenges that are brought about by COVID-19. So a look at question of vaccine development, then vaccine justice, and then the same thing that Xavier closed with, which is vaccine hesitancy and the need for public leadership and education in this area. So I want to underscore what I would call the blessings of modern science and medicine. It's probably a perspective that comes to me because I spent most of my adult life in a lab. And so have been and had the privilege of sort of watching science progress in ways that what we're doing in these days with vaccine development wasn't even thinkable 20 years ago. And so to appreciate what's gone into it, in particular from the perspective that this is the world working together to do that thing. Yes, we do wish to make you whole. We do wish to heal you. And I think that's something of what we need to appreciate about what medical science is trying to do in this moment, but also to get our head around the science enough so that we know where the real issues are and can be involved in the educational process that helps us at a societal level make good decisions. And so just to note that there are large numbers of teams, some people will say in the hundreds of scientists working around the world to bring about vaccine and treatments and therapies, because we know just following the popular press that there's new therapies always coming online. So to look at the issue of vaccines, the two vaccines that have been approved in Canada and are being administered in Canada are both of an amazing new variety of vaccines. These look nothing like the vaccines that they were being given when most of us were born. So the two in Canada right now are from Pfizer BioNTech and from Moderna. And Moderna's been supported quite a bit from the National Institutes of Health in the United States. These are about as clean an idea of vaccine as you can imagine. And so one of the things behind vaccine hesitancy is they're dangerous. Well, this new variety of RNA vaccine where you make I guess, a lipid molecule like a big soap bubble in which you stuff in some RNA that codes for these spike proteins that you can see on the surface of this model of the virus. And that is injected, and that stimulates an immune response with an astonishing level of effectiveness. So this 95% zone effectiveness is really an astonishing quality of vaccine. We do not usually see vaccines being that effective. And if you've been following this conversation in the popular press, and I think it is worthwhile, I'm mostly going to reference the popular press because that has something to do with how people understand many of these challenges of COVID-19. And so these are the two main vaccines that are being used in the developed world right now in many of the global north nations that can afford to get access to them. But there's a whole number of other vaccine options that are being taken. If we think back to things like the vaccination program that was quite spectacular in its time in the 1950s against polio, remember that there were two varieties, Salk and Sabin vaccines, one what they called a live attenuated virus, the other I killed injected vaccination. These different vaccine strategies have different advantages and disadvantages. And so as you can see, there are just a very short list of the hundreds that are being worked on right now. And the Pfizer and Moderna ones I've put at the top. They are really the rock stars of the business at the moment. But they have some challenges in the sense that they're kind of a sensitive biological product and need quite a bit of care in storing them until they are injected, either -70 storage or -20 storage. And when we think of the global vaccination program that eliminated a disease from the face of the earth, smallpox, that vaccination program was done in the 50s. In the 70s. And The last couple of places where there were still outbreaks of smallpox were in mountainous regions and the western border of Pakistan, and in Ethiopia, where there were active civil war activities. So you couldn't carry the -70 freezer on your shoulders when you went into these remote areas. And so you have to have, one thing about vaccine development, you have to have vaccines that can be delivered to countries that don't have heavy medical infrastructure. So that's one of the reasons, one of the important reasons for working on different vaccine strategies. And we can talk about that more if it turns out to be part of our question sessions. So this is just that point about the need for vaccines that are portable. Also, as Xavier mentioned, there is a global initiative to try and ensure equitable access to COVID-19 vaccines, regardless of the income level of the country. And this group is organized to a significant degree by the World Health Organization. So the World Health Organization has got this COVAX system going. All sorts of countries signed in on it. But what does your signature mean? We're beginning to recognize that just like signing in on the Paris Climate Accord doesn't mean we're going to do anything. So since you're allowed to be critical of your own country, here the conversation with Canada, who's signed on, we are having trouble with our vaccine access right now. So that creates a very particular situation for sharing your vaccines. So the term that keeps being used is sharing your surplus vaccines. And we're not sure what that means. I haven't seen any conversation about we're going to share a percentage right from the beginning. So the possibility exists that we might only start sharing after our own population has been vaccinated. So that's a real problem if it's going to take us a year to vaccinate people. The pandemic is a global issue. We think we can take care of ourselves first. That poses some serious ethical problems. And the Canadian government is skirting around it right now because they're in this tight space of actually not knowing where our vaccine supply, how our vaccine supply is going to be working. Here's another thing in conversations with South Africa. They have brought up this idea of vaccine apartheid and chasms of inequality, where inequity, where certain nations have lots of access. Canada has purchased access to probably about 5 times the number of vaccines that we need as a country. At the moment, though, we don't have a surplus. So how is that vaccine sharing going to work? And as Xavier mentioned, some very few countries in Global South have received much in the line of vaccinations, and only a couple of dozen that were obtained through a Russian vaccine trial have been used in Africa. So Africa as a continent is basically unserved by any vaccination program at the moment. Here's another shocking situation that the Bishops' Conference in Myanmar is urging the people of Myanmar to make donations, financial donations, so that the country can afford to purchase vaccines. This kind of crowdfunding by the church is a tragic situation. And I think to know about these situations, I think should spur a more assertive conversation about how we share these limited vaccine resources with the world. And This COVAX activity is a growing situation. They have recently convinced Pfizer to sell them a small number, 40 million doses of the vaccine in the first quarter of this year. They figured that that was a good start. And one of the points that COVAX organization hopes is that this news that Pfizer will sell them this number of million doses will help to jumpstart countries to say, look, we have to get on board now and begin to share our resources. And finally, this notice from Science magazine from just yesterday, that the new US administration has finally joined the COVAX program, and that kind of movement brings hope that the COVAX consortium will have more success in getting vaccines to people. This question of vaccine hesitancy, again, to echo what Xavier was saying, I think there are a number of issues that contribute to it, and this distrust of science, I think, is one of the reasons why I think it's worthwhile to have an effective public conversation of what these vaccines are and how they work, because one of the anti-vaxxer activities that has been going on for a good solid decade or more now in North America, in the West, is that these vaccines are unsafe, and in particular, they're unsafe for children. There's also questions of certain communities within a country that have good reason to distrust the authority figures, to distrust the government. And so one needs to build relationships of trust. And then there are sometimes you hear about the faith-based, the religious-based objections that are accepted for all sorts of government programs. And I think that in most cases, these faith-based objections to certain medical treatments, including vaccinations, are in fact the basis of, are based on distrust and poor information. And so I think, again, that education can be a huge component of this, and again, building trust. So in places where faith communities have not trusted government vaccine programs, it's found to have been helpful that members of that community who were educated about it. I know of cases where nurses went into the communities, their own community, which was showing resistance to the vaccine, and they said, look, I am one of you, I am of your tribe, and here's how vaccines work. I took it, I gave it to my children. I think you need, for the good of the community, to get on board. So we need to use the resources of the community to deal with questions of vaccine hesitancy. So just to summarize, then this question of vaccine development and supply, I think we need to have an appreciation and an understanding of what's happened here, that within a year of encountering a brand new disease, we have a vaccine. That would be a historical first. That kind of movement has never happened. Usually you think of vaccines to develop in decades, not in months, less than a year. And also where we are in the power of science today, these vaccines could not have been created 20 years ago. So there's a lot to appreciate there, and therefore an educational moment about the power of science to contribute to the health of the world. Then there are these questions of vaccine delivery that we've both talked about. There's the question of vaccine hesitancy. And again, I think we need an education and a conversation about community. There are also new things. I think we hope that the vaccine is going to cure everything. But if one's listening to the popular press these days, we know that there are new variants of this SARS-CoV-2 virus coming up, and we're not sure what that means. And so we also, as we're pushing for these vaccines, need to help people continue to engage good public health projects, good public health practices. And that's also underscored by what I've called salvation by technology. For us to not look to the solution coming simply by means of technology, that there are human engagement, there's the building of community that needs to be part of this solution. As Xavier had underscored, this global pandemic needs a global solution, and it concludes the issue of solidarity and the desire to care for one another. We can't solve a global problem by simply caring for ourselves. And so as we move forward, I think any reflex that we have that says we're just going to go back to the way it was ignores some of the lessons of this pandemic, which has exacerbated inequalities in individual societies and throughout the world, and therefore a need to build societies that are more resilient for human beings and for the planet, need to build partnerships globally and locally for healthier, more sustainable world. So I think I'd like to stop there. Thank you.
Xavier and Father Rob, thank you very much indeed for those absolutely wonderful conversation and reflection starters. We are greatly in your debt. I'll now ask Mary Kate Gorky to take over control of the meeting, please, Mary Kate, and just explain how we're going to proceed and then initiate things.
Absolutely. Thank you. And thank you to both of our speakers. That was really a wonderful way to start us thinking about these issues as a community of scholarship. So looking forward to the live discussion. I just wanted to, I guess, add a couple technical points of assistance to get us all going. For those who are less familiar with the Zoom platform, in the bottom corner of your screen, you should have the option to mute or to stop video, and keep those options in mind if you choose to participate live. When I introduce the options for your participation, you need only to click those options. So if you're muted, it'll have a red strike through it. If you're unmuted, it will not. You will also, further across the screen, if you proceed through the options, there will be a chat function. Or if you do not have the chat function, there should be an option that says more ... And if you click on that, up will pop a list, and from there you will have the option to click chat. The reason that is important is because that is how you will be communicating how you would like to contribute to discussion today. We recognize that we are not going to be able to cover every question or every topic of discussion because there's a lot to talk about, but in order to encourage active discussion and try to synthesize things as best as we can to keep the conversation moving, we ask that you choose one of two options. You can either indicate that you would like to participate yourself sharing the question by, in the chat, typing the name that you'd like to be addressed by, a question mark, and then the topic of discussion. So for example, global distribution and access issues, or responsibility in the common good. So again, that would be the name, a question mark, and topic of discussion. And then you will be called on by Dr. Bill Sullivan to participate. The other option, if you would like to remain anonymous, because again, this will be recorded, or if you would otherwise prefer to type it in, you may just type your question out, and then Dr. Bill Sullivan will contribute the question on your behalf. So again, those two options, either type your name, question mark, and the topic of discussion, or type the entire question out and it will be recited on your behalf. Okay. As questions are starting to come in though, I believe we'd like to turn the conversation back to Dr. Symons and Father Rob Allore to see if they have any conversation that sparked from each other's presentations, just giving them the opportunity to kind of ask the first questions.
Thanks very much. I'm happy to go first. I think there was some very helpful complementarity between the two presentations, which was great. I suppose, Father Rob, I was wondering if it was interesting when you used those vignettes of, for example, in Myanmar, of the crowdfunding to sort of, I suppose, to try and find some money to purchase vaccines in developing countries. I noticed in the Pontifical Academy for Life, they released a document at the end of last month where they were talking about strategies to ensure equitable distribution of vaccines, and they actually kind of talked about the church playing an active role in trying to help facilitate that, and kind of like sort of diocesan level organizations trying to support governments in basically ensuring that kind of equitable vaccine access. I was wondering if you had any comments on what a kind of a healthy relationship and a healthy contribution of the church might be in relation to the distribution of vaccines. Obviously, in Myanmar, it sounds like the situation is pretty dysfunctional there, where basically the church has had to kind of do something that one would hope would be done by health authorities. But yeah, I was wondering if you could comment on that topic.
Well, I think the church will have different strengths in different countries, and to go with our strength, I think one of the big things that the church is already doing is speaking out about the need for everyone to get vaccinated. So to make sure that Catholics, that believers of whatever stripe who perhaps look to churches for some leadership, that they hear that the church wants us to get vaccinated, and even speaks with the language that you did, Xavier, about this need to support the health, the common good, by doing your bit to get vaccinated. And that Pope Francis, even with the sort of small city state that he's in, that they're pushing for vaccination of the homeless in Rome. So to do the double thing, to make access available to the poor and make sure that they get vaccinated, to push the general idea that vaccination is a good, because people will look to the church for leadership in that. And then the church has other institutions that can be very helpful. Obviously, the healthcare network of the church around the world, my understanding is that there is, it's the largest healthcare network on the planet if you take together all Catholic health services. And so obviously the church then has boots on the ground that is able to facilitate the vaccination process, because that's going to be one of the challenges in many developing countries, which is healthcare infrastructure, and the church can be part of that, even to the point of groups like Jesuit refugee services that are out in the field. And if you're trying to vaccinate at refugee camps, that between church-based or faith-based refugee services and groups like Médecins Sans Frontières, that those groups together can do a lot of work. I was at a World Council of Churches forum a while back, and they were speaking about how different faith-based groups, Christian and non-Christian, cooperated for the delivery of health services in refugee camps. And the cooperation is spectacular. And I think that preaches God's care for the world through the people, sort of thing. So I think there's a number of approaches that the church can take, but this encouragement to get vaccinated is a huge thing. So it's wonderful that the church is speaking that, and then go with our strength, whatever those strengths are in different countries.
Excellent. So my name is Bill Sullivan, and I have the pleasure of kind of facilitating this dialogue at this point. And just to sort of put this in a little context, we are expecting to receive many more questions than we can actually ask. So it may be that we will have an opportunity to respond to more detailed questions following the webinar. So I've got a little team here helping me to kind of think about themes and fairly high level sorts of questions. One of the things that struck me about your presentation, Father Rob, was that this is astounding, that this vaccine, the efficacy of it, and so on. I guess one of the things that is in the background is how bad is this pandemic? Because I think that that's often when both individuals and public health people are making a decision about interventions, it's in the context of basically how bad is this? Any kind of comments on that? Because it does kind of put this efficacy question into a context. You're on mute, Father.
Share. I mean, I think it's very bad, right? I mean, the kind of global numbers of cases that they're giving right now is over 100 million cases, and global deaths in the two and a bit million cases. So even looking at the global cases, 100 million. I think when we had SARS round 1 in 2003, they're talking about 25% of the people who had a disease from SARS, a clinical manifestation of the infection. 25% of them have long-term health complications. So if you have 25% of 100 million people having long-term health complications, that's a huge burden on healthcare infrastructure. Remember when I was doing public health in Northern Ontario around questions of diabetes and reading about the global burden of disease through this one condition, diabetes. And they were talking about the growth of type 2 diabetes in India. And they said at the rate of growth of that condition, often due to westernization of diet and culture, that the growth of that condition would cripple any healthcare system imaginable. My concern is that if you're dealing with 25% of 100 million, and we're still counting, and we're in a very serious growth phase of this disease, 25% of 100 million is going to have a crippling effect on a lot of healthcare systems, just the way in which the AIDS pandemic did.
Exactly.
So
yeah.
It's serious, and the deaths that are occurring, they're tragic.
Thank you for that.
Yeah.
Just kind of following up a little bit on Xavier's presentation where he highlighted the vulnerable. I guess one of the things that was just mentioned is the burden of the pandemic. And Xavier mentioned social determinants of health. And I guess one of the things that doesn't seem to be in the calculus of the public health framework of kind of mortality risks is all those people that are suffering who are not yet infected. Any comment on that, Xavier?
Do you mean, could I just a clarificatory question? Do you mean, in terms of the people who are suffering because of like the various societal effects of the pandemic and that, yeah, who
Yes.
don't necessarily have the virus, but in a sense have been affected by the pandemic indirectly?
Yeah. So I guess, for example, I'm thinking of, you know, people with, say, intellectual disabilities. And in the US, 25% of them have lost essential services now for over a year. So it's that sort of burden that doesn't seem to be factored in to kind of a public health perspective.
That's right. Yeah, no, I think that's a great point. And I mean, all I can really do is elaborate. And I think the fundamental observation is correct that we have a fairly, like, the metrics for measuring the impact of the pandemic are fairly simplistic. I mean, obviously it's important to take into account mortality rates and kind of morbidity. And as Father Rob rightly pointed out, the worrying rate of complications that long-term complications that people experience. But I mean, the social costs of the pandemic, if you're looking at kind of just sort of broader societal impact, I mean, arguably that's even more significant. Like, that's one of the most significant things. I mean, the social isolation that people are experiencing, and then specifically, as you mentioned, like this compounding of sort of existing vulnerabilities. So I think there's something about the nature of the pandemic that makes life in society much more perilous for people who are kind of vulnerable and marginalized. So, I mean, social services tend to struggle in these kinds of situations. And as a result, people, as you mentioned, with intellectual disabilities, people experiencing homelessness, people with kind of, ongoing health problems, they receive substandard care and attention. And so it really is a catastrophic situation, I think, in some countries. And it's only really probably once kind of the pandemic's over that we'll realize just how profound the effects have been on certain communities that maybe don't get a voice in the media necessarily, like when sort of there's so much else going on.
Right.
Anyway, that's
great.
What I
Yeah, thanks. So you know, it strikes me that part of the discussion has been about the economics behind all this, and that the global side of that. There's also a very important public health perspective, and we happen to have with us Jim McManus, who is very involved in public health in the UK, and I'm just wondering if I could invite Jim to kind of share that perspective or any comment you might have on this.
Thank you, William, and good evening or morning or afternoon, everyone, wherever you are. It occurs to me the last time I participated in one of these, I was actually speaking in 2009 by telephone during the last pandemic, which makes it. My day job is as a director of public health, but I'm also vice president of the UK Association of Directors of Public Health, and I sit on both the National Vaccine Delivery Steering Group and the National Vaccine Equalities Board and the National Outbreak Management Board. So I see things on two sides, and I couldn't be more heartened and encouraged to hear the application this evening of some of the principles of Catholic social teaching, because it feels to me that Catholic theology and Catholic bioethics has largely ignored public health in many respects. And what we know is that the people who are hit hardest in public health crises are those who bear the greatest burden of inequalities in society anyway. And there's a well-established principle in public health called the inverse care law, And I think there's a huge amount of scientific evidence which shows that those who are best able to take up the vaccine are and have the least barriers are those who get best access to protection. And to me, that's a very theological issue as well as a public health issue. And it strikes me that without wishing to prolong this, I think there are several areas where I think Catholic social teaching has much to offer public health practice, because the dilemmas I have faced during this pandemic are, how do I store enough bodies? What do I do with the fact that both of my hospitals are now full and we don't have, we've actually had to treble the number of intensive care wards we have. We have 500 people in our hospitals in Hertfordshire, which is about a third of the hospital capacity. We also have many thousands of children unable to go to school who can't learn. So the impact of this pandemic is wide. And it feels to me that there are no completely easy cards. Every decision we make has a downside. And lockdowns are, one of the worst options, apart from all the others, which are also all the worst options. We are in a place where the playbook for this virus is difficult. So I'd like to just suggest some areas for theological inquiry. I think the issue of inequalities is hugely important, both in terms of the ongoing impact of the pandemic, as well as access to vaccines. I think there is a massive issue about transparency and participation in policymaking, where some governments have failed to bring their populations with them. And I would see that through the lens of horizontal subsidiarity, the important principle of subsidiarity in Catholic teaching, which I think we have much to bring to bear. The recent English decision to delay the vaccine by 12 weeks between doses, for example, could hardly have been communicated less well to the population. I think there is a major issue about hesitancy, which brings significant issues about subsidiarity and solidarity and our ethical responsibility to avoid misinformation. And then there is the massive issue of misinformation and whether we see our role as Catholics as entirely individualized. My right to attend church without wearing a mask and receive communion on the tongue and not in the hand, despite the fact it may infect somebody else, or is our duty to precisely in solidarity. And I think we've become too individualized in much of our ethical presentation. And finally, I'd very strongly encourage you to do multidisciplinary work. At the minute, much of what I'm doing is on vaccine hesitancy. And I probably have conversations with, at the minute, 200 social care workers every day by means of webinars. And vaccine hesitancy is very real. But we can't allow behavioral science, which is important, and I say this as a psychologist, to go without theological and ethical scrutiny. So that would be an invitation from me that public health absolutely needs what you do, and an invitation to partnership. And I know a couple of you have messaged me in chat, and apologies, my chat's not working, so I can't respond. I'll stop there. I think I've spoken far too long. But may I thank you for your invitation, and I'm happy to put that in an email to John, so you can ignore what I've said at your leisure.
Thank you very much. Really appreciate that. I guess as a kind of a follow-up to this very commonly asked about question, which is vaccine hesitancy, I wonder if I could call on Marlene Van Lythen. She's a clinical ethicist from London, Ontario, who had something to say on that topic. So Marlene, if you could just unmute yourself, that would be great.
Great, so thanks very much. What I wanted to share, I'm thrilled that the comments so far have really talked about the importance of trust. And I want to share that I had the opportunity to attend a really great webinar this past week by a professor from Guelph, which is a university in Canada. It's Professor Maya Goldenberg, and I'll send some of this information through the organizers. But I want to just give a quick blurb about vaccine hesitancy. And she has a book coming out in the spring subtitled Public Trust, Expertise, and the War on Science. So part of what she said was, of course, if it's an information gap, these conversations need to be sensitive to the audience, many of whom harbor distrust of the sources of scientific information or the healthcare system due to systemic problems. And then really specifically to healthcare workers and their vaccine hesitancy, she says, this distrust is no less for healthcare workers, many of whom have suffered various kinds of trauma and feelings of helplessness and disempowerment during these hard months of the pandemic. So I just wanted to share that with the group.
Thank you very much. Again, lots of comments about this issue. You know, another common topic that's come up is on this whole issue of global access and distributive justice. Michael Wee is on the line. I hope I've pronounced your name correctly. He's from the Anscombe Centre in the UK. And Michael, if you could please unmute yourself and pose the question to the panelists that you had.
Thank you, William, and thank you to both panelists for your excellent talks. Now, I have to say, I agree with most of the broad principles outlined, if not all. You know, vaccines are a common good, a common resource. A global problem requires a global solution. I have no doubts about the truth of those statements. I just wonder, Xavier in particular, you quoted the Director General of the World Health Organization saying that, you know, it's better to have fewer people from many countries vaccinated than a lot of people from fewer countries. And my question really is, does fairness and solidarity on the global scale necessarily mean countries doing things at the same pace? Is there an argument to be made, especially on the principle of solidarity, that the nation state perhaps from the point of view of efficiency, efficient distribution is a better level at which to make such decisions? And furthermore, if you let, you know, some nations go full steam ahead, even at the expense of others, it does mean, you know, it's a global problem, but outbreaks are local. If you have, you know, more and more individual nations becoming, you know, reaching full vaccination, hopefully becoming like Australia and New Zealand, becoming more or less COVID-free, who can get their economies going, isn't that, you know, another way of approaching fairness? Not necessarily everyone going at the same pace.
Okay, I'm happy to make a start on that. So thanks very much, Michael. I think that's a fantastic question. And yeah, I think there's something to the question of kind of efficient distribution of resources and the principle of subsidiarity as kind of complementing some of the principles that I outlined. I'd say, I suppose I'm going to put a few considerations on the table. I'm not going to provide an exhaustive answer to your question, but I mean, a few things that I think would be relevant. One would be that I do think that in terms of reducing the global mortality rate, if you're just thinking about kind of reducing the sheer number of deaths from COVID-19, then it is true, I think, to say that it is better for a few people in many nations to be vaccinated than many in a few nations. So that is a very powerful consideration, I think, just to kind of have in mind that insofar as we're trying to, if you will, like reduce the worst effects of the worst of the effects of the pandemic, namely mortality and then sort of severe morbidity, there is something very powerful about this idea of kind of looking at how we might spread vaccines more equitably. I do think there's a question like about whether we need to take an either or approach. So I wouldn't want to be mistaken for saying that the governments don't have a responsibility to their own population in a sense, like that is a very fair, eminently reasonable comment to make, and I think that's something we do need to have in the background here. But yeah, I think, I mean, I would argue that there are some nations that have made it such that they're currently unable to assist other countries, or if you will, like that it's more difficult to assist developing nations. So they've put themselves in a position such that that's the case. And I mean, to use one very simple example, I mean, the US has only just become a signatory to the COVAX facility. And I mean, it perhaps would have been helpful if they kind of made, like, signed on to that agreement earlier. Not that COVAX is kind of, as I mentioned, not that it's necessarily going to solve all the problems, but I think, I mean, at least sort of just having a commitment, some sort of a commitment to equitable access does help. So those are a couple of comments. I mean, I know it's not, I think you've got a good point there, but yeah, I think those are some things to bear in mind.
Excellent, thank you for that. So I think that I'm mindful of the time. We probably don't have much more time. And I think we've kind of covered some of the broad areas. I guess one of the questions I think that has been raised has to do with this idea of that's maybe an unstated assumption that we can achieve herd immunity, and that once we have herd immunity, we'll be fine. Now, some people mention that certain countries only have access to vaccines that are less than, maybe less effective. So even if they vaccinated everyone, chances are they wouldn't reach that. I think they're talking about 85% of the population for herd immunity. Now, so this might be a bit of a technical question for Father Rob. I guess they're asking, if you, first of all, can countries actually achieve herd immunity? And secondly, if you can't, does that change the thinking about distributive justice?
Well, thanks, Bill. I think one thing to remember about all of these questions is that everything about COVID-19 is a work in progress. We know we are scrambling. And so I think these conversations about kind of what principles will we use to make these decisions that need to be made on the fly, these are important foundational conversations. And the question about herd immunity, what level do you need to have in vaccination if you've got a vaccine that's something like these hot new vaccines that have about 95% level of effectiveness? I mean, it looks like from places that have had heavy infections that you are going to need quite a high level of vaccination to accomplish herd immunity. So that becomes a serious challenge in itself. It's not 50% and it's not 60%. It's probably in the 80% zone before you can think of it, because it looks like regions that have sort of 70% exposure infection rates still have a heavy transmission load. So the question of herd immunity is going to be challenging. I think the appearance of new variants puts that also into question. But all of the vaccines that I've seen results on the trials, not everyone has this 95% effectiveness, but most of the vaccines have pretty solid effectiveness in reducing death and serious disease. Well, those seem like pretty serious goods to pursue. So I think one keeps moving with these vaccination programs and with the vaccines that you have access to, some of which are still to receive approval. And so I think just to keep with those programs is one public health good. And then there are, the decisions in this province, in the province of British Columbia, seem to have been quite reasonable in the vaccination process, in that they pushed very hard in this province to get those living in long-term care environments and those working in those environments vaccinated first.
Yeah.
And
okay.
So as of yesterday, I think they felt that they had a good portion with 2 doses already, and everyone in that environment with 1 dose.
Great.
And that is everyone that accepted it. People have mentioned vaccine hesitancy. The good news in this province has been that the uptake of vaccine has been higher than the normal level of uptake for other vaccination programs like influenza. So
Great.
I think to protect the most vulnerable, to try that first, I think is still a good strategy, even if you don't have a 95% effective vaccine.
Sure. Great. So thank you very much. I think that that will be all the questions we have time to ask. You know, it's one of the things that...
Did you want to say, let Jim McManus, he had his hand up there. Did he want to comment on that last one that you asked me, Phil?
Well, I think just because of the, we want to stick to our time and it's very tight. What I would ask is those who weren't able to ask questions, if they could type them to IACB, and it would be jheng@uwo.ca. And then we will save any questions that have been asked and have a response afterward. So I think the final comment I would make on this whole question of hesitancy, I was noticing that the World Health Organization lists it among the 10 top threats to human health. And what they conclude is that it's the person, probably the primary care provider in the community who's trusted, who will have the greatest impact, and they need to be supported. So that might be a take-home lesson, because I think many people on this call fit that profile. So maybe I'll just turn it back to Bernadette to have some concluding remarks.
Bill, thank you very much. And I would like to thank everybody who has participated, including those who have simply listened very carefully and those whose questions we were not able to get to. As I said at the beginning, this is the first of 4 sessions, and everybody who has enrolled in this one will be invited to the next 3. I have a bunch of things that I would have liked to have said by way of summary. Lots of the questions, well, let me say this. Jim McManus said public health needs what the IACB is doing. Lots of the questions raised were, part of the problem was, are they technical questions or ethical questions? Is few in many countries better than many in few countries? Is that a technical question or an ethical question? Or does it involve considerations that belong to both those realms of discussion? But let me finish with this. Father Rob reminded us of a religious understanding of human beings. He reminded us of the story of the man with leprosy who said to Jesus, "If you wish, you can make me clean." And the reply was, "I do so wish." And Father Rob said that we need to be aware of our obligation to respond, "Yes, we do so wish." Now, here's my final point. We hold that out as a moral teaching, as a matter of public reason. That is a matter that is acceptable and accessible by any human being of goodwill. So our holding out that conception of a human being as a to-be healer, we need to accompany that holding out, that teaching, with accepting the argumentative burden of making that moral and political teaching clear. So I would like to thank everyone for participating today. I think we tried to do that this morning. So good morning, good afternoon, and good evening to everyone. See you next time.
Thank you very much, everyone. Thank you.